Hello and welcome to Exploring Global Problems, a podcast where we talk to academics from Swansea University whose groundbreaking research is tackling global challenges, from health innovation to sustainable futures and the environment, from digital technologies to clean energy. My name's Sam Blaxland, and today I'm joined by Jo Davies, Associate Professor and Director of Simulation Education for the Faculty of Medicine, Health and Life Sciences here at Swansea. Jo's research focuses on advancing medical education through simulation and immersive technologies. Jo, welcome.
Thank you. It's lovely to be here. Thank you for asking.
It's our pleasure. It's very nice to see you. You had a very varied career before you came to Swansea. Yes. Tell us about it.
So originally I'm from a place called Keele, Scotland, near to Keele University. And that's where I trained when I was 18 to be a midwife, actually. So my clinical background is midwifery. I've been a very proud midwife for 30 years, so a long time, showing my age now. Shouldn't have said that bit.
You started when you were 2.
Yes, I did, yes. Definitely. And during my career, I actually travelled, although I worked in the UK, I also travelled abroad quite extensively. So I've worked in Saudi Arabia, Abu Dhabi. I've worked in Qatar and Australia. During that time, I've mainly worked on sort of labour and delivery units and helping families and women with their birth experiences. But I also became very passionate during that time about education and expanding my experience in education. So when I was in Abu Dhabi, I sort of set up a bit of a simulation program just out of interest. And then when I moved over to Australia, that interest grew, and that's where I studied my master's degree in that field in health science and education, using simulation as a methodology, and it's sort of taken me around the world since then.
Wonderful. I will come to simulation in a second, but being or working in those very different cultures and environments must have been interesting.
Yeah, it was absolutely fascinating, because I think not only do you grow and learn about the different cultures and experiences, but you also see the very humanistic side of how we're all very similar, especially in the types of environments I work with, where often families are quite vulnerable. They're experiencing great joy, occasionally great loss, unfortunately. It just widens your world working abroad. I think it widens your experiences, and you get to know wonderful people.
Challenges from working in places in the Middle East as well? Obviously, they would have operated around issues to do with birth, I think, quite differently.
Yeah, there was differences, but a lot of similarities. I think they're working very hard to integrate different international standards. Their hospitals are accredited. They bring over expatriate teams to really help support and grow those programs. So I think there's challenges in every healthcare environment, but they do overcome it with great enthusiasm. And what I really, truly valued about working in the Middle East was that they were highly innovative. They really wanted to grow and expand, and often had the resource to do that.
Great.
Yeah.
So you mentioned simulation. I mentioned immersive learning, I think, in the intro there too.
Yeah.
What do we mean?
What is it? Well, simulation isn't new. It's a way that we can. Predominantly, I work for the Faculty of Medicine, Health and Life Sciences. So my experience has been training healthcare teams. So we train individuals and teams, and we review systems using simulation-based learning, which is really immersing learners into highly realistic environments. And we do this in a number of ways. Everything from, I don't know if you've ever seen the mannequins that we use, but we have these mannequins that breathe and cry and seize, and they give birth. And they do really everything that a human person would do. We also work with actors and our community patients to actually run cases and scenarios with actual people that are demonstrating different social needs or cases. And then we're actually advancing, especially with the work at Swansea University, to include immersing learners in actual environments. So our new centre has immersive wall technology. So we can create a number of rooms, whether that's a home, whether it's an A&E. We have a big operating theatre, but the walls come alive. They have people embedded in them. They have sound. We even have smell boxes. So if we do something like a surgery, you would smell a little bit of blood, or you would smell the anaesthetic-y clean smell within the theatres. So it's just wonderfully creative. But the most important part of that is that by immersing those learners into real world experiences, they transfer their learning into clinical practice more effectively and efficiently.
Tell me a bit more about these walls coming alive. I get the idea of the smell aspect. That's fascinating.
Yes.
But how do you mean exactly?
Yeah, so we have projectors that are hidden and mounted in the ceiling. And we film with 360 cameras, various environments. So we've actually been very lucky here in Wales that the Health Board has really supported us to film in places like Glangwili maternity, some nursing homes, intensive care units, all the clinical areas that we would want our learners to use really as part of their training. So we actually play those on the walls. We have software so we can play them on the walls. So when they come into the environment to care for the patient, they have the noise, the distraction. It isn't just a sterile classroom, but they have the phones ringing, the alarms bleeping, the temperature. We can adjust the temperature. Like we said, we can add the smells. So it really is highly realistic for them.
And I can see the huge value in this, in that so much of the criticism of practical degrees is sometimes that it's taught very theoretically and that it doesn't resemble the realities of working in a real environment.
Yes.
So you're trying to overcome that.
Yeah, we're definitely trying to emulate that. I mean, I appreciate that a lot of the healthcare courses, they do go out into clinical practice and they're mentored and supported. But how do we really equip resilience in our students? A great example of that is the paramedic course. We've got some fantastic paramedic students. And if you think about caring for a patient at the roadside, you don't just have the patient to deal with or family members. You have the road, the noise, the cars going past. You might have a car that's on fire or some distressing environmental situations. And over the course of their training, we can build those scenarios into their courses and equip them for real life practice.
Can you simulate someone, I don't know, throwing some litter out of a car as they're passing by?
You can do whatever you want.
Oh, wow.
You can simulate really. I think the beauty of the technology is we've got everything from a hospital environment to swimming with the whales. We use it for some groups that for well-being, for relaxation, for learning disabilities. The filming is endless that you can do. So you can really create these wonderful stories and scenarios for teams to practice. And we don't just work with undergraduate students, actually. The immersive wall capabilities means we can work with postgraduate learners, which is really important for maintaining competency, and also industry.
So just practically, talk me through, if I walked into this space or one of the spaces that you use, I mean, is it a big room? What would I see? And how could you flick a switch or make something happen? And how realistic would it feel and would it be?
Right. So we actually have two facilities. So we have the Haldane building at Swansea University main campus. That's 2 floors. And we have what we call 4 zones of learning. Each zone has 2 simulation suites, and that has a classroom, a simulation immersive room, which we've just described, and next to that we have a control room. So as faculty or the simulation technologists would sit in the control room and view live what was happening in the simulated space. Within the classroom, the other learners that aren't in the simulation would be watching live from the classroom. So all the rooms are highly connected.
Amazing.
So that I always say you get sort of 3 for the price of 1. You might be in one, but you're gaining that learning experience from several simulations. And the student feedback has been exceptional. They're really immersing in these environments. They take things seriously. They wear their uniforms. They do things in real time. They communicate effectively with the patient and each other, because we know from research that one of the leading causes of preventable harm in healthcare is actually team performance and communication. It isn't the skill of what we do. So we're finding the results from doing what we call this applied simulation incredible.
And I know, well, I know, I get a sense from the news and from the media that there is a shortage of healthcare workers, or at least retaining a lot of healthcare workers is a real problem. And I assume that part of the purpose of all of this is that it will help somehow with that problem because people will be better equipped and trained when they go into scenarios?
Absolutely. I mean, it's a huge responsibility, isn't it? Any healthcare profession, whether you're a nurse, a midwife, a doctor, an OT, and the pressures are high, but they're wonderful, rewarding careers. And to be able to help students build resilience and confidence to go out in practice, to be able to support postgraduate learners to maintain competency and just practice together as teams is all helping not only to improve patient safety, but to equip resilience in our healthcare teams. And I think that's really important. We're also advancing the technology for that capability to happen because, as you rightly said, the challenges in the NHS are huge, and we want to keep staff by the bedside. We want to keep our healthcare practitioners at the bedside or out in our communities. So to be able to use things like our virtual reality technology, more bite-sized learning opportunities rather than mass training events is only going to help in the future with the challenges of maintaining competency in healthcare.
I want to ask about the VR in a second, but just going back to the mannequins for a second, which you
Okay.
mentioned.
Yeah.
I mean, I'm just thinking of the very basic mannequin that I learned how to do CPR
Yes,
on. But
yes.
your mannequins can give birth, I think you said a minute ago, which
they've come a long way.
Well,
Yes.
I mean, tell us a bit about that. I mean, I have no direct experience of childbirth, thank goodness, but I hear it's quite an intense process. Is that reflected in what these mannequins can do?
As a midwife, I can guarantee
you've probably
that we need
you've seen a bit more than me.
I think the absolute important part of any of the technology is it's driven by the education. So we have a range of technology within the centre. As you said, you might have seen quite a basic mannequin, but for CPR, that's all you need. Sure. So that's great. So we can buy those a little bit more en masse and do that type of training. But the range of mannequins we have, and we have named them, so they are becoming part of the family. We're getting a bit too attached, I think, but we have everything from newborn babies to children to adult mannequins, geriatric mannequins. So we have the real range, and each of those mannequins have slightly different technology.
Can they talk?
They do talk. So we've got some pre-programmed, but the majority of the time they have either Bluetooth technology or we have a microphone. So when we're watching the scenario, we can be the voice of the mannequin and respond in real time.
You can go, ouch.
You can actually sort of really recreate the realistic. So some of the mannequins we have, you can do everything from sort of intubating, so everything to do with the operating theatre, different procedures. They seize, they cry, they, as you said, give birth. So they really help to create that what we call fidelity, which is realism for our training.
What are some of their names?
We've got Maud.
It's a very frivolous question, I'm sorry. But...
We've got Maud, who's our geriatric patient. We've got Dave, who's our sim bodies. So Dave's one of our favourites because it's actually made from a company that does work for TV. So they're highly realistic. Oh, wow. They really do look and feel. And
do they have like sort of skin and hair
they do
and things
now.
like that? Yeah.
And I think the advances in the technology has been incredible because instead of them being plastic, they used to feel and look a little bit unrealistic. Now with the advances in silicone, and I mean, they really do look, I think people are almost shocked. And I have to say, our poor cleaners had a little bit of a shock the first night they met them, which we're now very familiar with where they are. But sometimes you do have to definitely introduce people to the fact that these are mannequins and not real people.
Amazing. What about the VR training then? I said we'd come back to this.
Yeah, the VR training's just been incredible. We were very blessed to be awarded significant funding from the Higher Education Council Funding of Wales, actually £900,000 to help create a bespoke curriculum. Because some of the challenges of VR, it is in the early stages relatively, especially for healthcare. And we also have to think about when we buy in curriculum, we have to maintain things like licensure fees, etc. So what we've done, we've worked with local industry, local companies, and some of our former students, which has been fantastic, to create a library, a platform of different modules, ranging from everything from shock cases to diabetic cases to neonatal cases. We have a real varied range. And we've actually created a platform that not only can you go in as a single learner, but you can actually come in as what we call a multiplayer. So the teams from wherever they really are, if they've got a headset, can come in and train together. So the next phase of our research is rolling that out at scale within our university and our partner, who is Hywel Health Board.
Again, just a practical question. You said headsets a second ago. Are
Yes.
we literally talking about putting headsets on and
Yeah.
seeing
Yes,
alternative scenarios?
absolutely. So we have headsets. They're sort of the big goggles you
Yep.
might have seen, yes. And you really do sort of immerse. That's genuine immersive learning, because you're in an environment. We use a combination of what we call 360 video. So again, we've got a case around delirium. And one of the things that we like to do with VR, and the company I worked with, Rescape and Immersive, they're really great at sort of doing that patient journey and the lived experience. So even though we do training in VR, we often flip it to a lived experience as well. What does it feel like when you have dementia? What does it feel like when you have certain conditions? And that helps build empathy within the workforce that we're trying to train, and sort of expose them to those different cases. So that technology is advancing so quickly.
Yeah.
But I think what we've tried to do with this project is mirror our simulation standards, but looking at ways we can roll out more training at scale.
Again, what kind of, if I came and put on one of these headsets,
Yes.
what kind of things would I be seeing? Would I again be potentially on the roadside scenario or in the operating theatre, all that sort of stuff?
So one of the cases actually we had a look at yesterday was a child case. So it was a little boy who has diabetes and he's not feeling very well. So you put on the goggles, you meet him, he's in a hospital bed and he's feeling unwell. So you can talk to him, you can do procedures, you can cite a cannula, you can put oxygen on him. You have the cart, so you walk up to the cart and you get all the equipment
blood
and
glucose test,
blood glucose, and really anything you would do. We script an exact scenario and it's replicated within the headsets.
Yeah. I guess someone who is hyperglycemic can smell of like pear drops or something.
That's
can't they?
right.
So you could even have that smell thing
That's
again.
right. It's and we're looking at ways within virtual technology, also sort of the more virtual learning, where we can also place that material into our immersive spaces and compare which sort of actually works best. Is this modality equal to this modality? So our research is sort of ongoing.
Are there drawbacks or disadvantages of all of this? I mean, we talk and have talked on the podcast before about AI and about the opportunities that poses, but also the challenges. And I wonder whether, I don't know, just thinking methodologically or maybe even philosophically about this way of learning, do people put forward potential problems?
Yeah, definitely, because I think it's quite resource intensive.
Yeah.
So often you have to, when you're planning any of these new centres or programmes in general, you have to think about not only the initial capital costs of the equipment and the resources, perhaps a refurb like we did here at SUSIM and Swansea University, but the sustainability of the equipment and also the expertise you need, because really your programme is only as good as the people that you work with. And we're very blessed to have an exceptionally good faculty. We do a lot of faculty development. We have sim technology teams and operations teams. That, to me, is required to run these programs successfully. However, saying that, you have to think about the value of this training beyond monetary value.
Of course.
So if our goal is to increase patient safety, reduce preventable patient harm, train teams together, maintain, increase student numbers, retain more people in healthcare, to me that outweighs some of that initial costs to set up the programs.
I think it sounds amazing. And I'm trying to find a devil's advocate position because I try and do that a little
bit.
And I'm wondering whether you could say that training people with in these virtual environments, could you argue that potentially that numbs them to the reality of the situation, because whenever they're doing their training, they always know it's not real?
Yeah, it's a great question.
And then how then do you transpose
Yes.
that to a real life situation?
Yeah. I think that's a great question. I don't think simulation is here to replace clinical care or the experience within clinical care. What we're trying to do is sort of be a great support system around that actual working with patients. We don't want you to practice on patients necessarily. We want you to do a lot of the practicing, make mistakes with us where we can debrief, we can talk about it, we can practice together. And then when you go into the actual clinical environment, you're more equipped. Because if you think about really all the care we give, if you've got, say, new students that need to go into an area and speak up, they might not feel comfortable to do that. They might feel a little bit intimidated, where we teach that that's a safety issue and we want you to speak up and you'll be celebrated to do that. So I think it really is that it's a support mechanism to prep for clinical care, not necessarily replace it.
I imagine this is a mannequin-specific question, but obviously a lot of medical training decades ago was done with cadavers, wasn't it?
Yeah.
And I assume that's
absolutely.
almost no longer a practice, and this is almost a replacement for that? Or am I wrong?
Element. No, they still have wet labs. So
Okay,
I think, again, they do have a mannequin, a sim cadaver. So they are sort of looking at ways because, again, wet labs and the running and maintenance of those and everything that goes along with it is challenging and probably expensive to do. But I think that type of training, when we think about training, we often say we scaffold. So it might be that they do some procedures virtually or with the mannequin, but they still would go ahead and do sort of the wet lab work as well.
Yeah, interesting.
Yeah.
You have mentioned people, organisations, groups that you work alongside, but obviously this kind of research, these kind of schemes involve a lot of collaboration, don't they?
Absolutely.
So do you want to say a bit more about that?
I mean, even from the work I've done internationally, you cannot succeed with these programs without great teams, great core teams, but immense collaboration. And that's sort of with your partners that within your institutes. The health boards are really important, your local health boards and industry. So sort of current examples that we have, we work with HNIW, they have sim deans, and we do a lot of work together for sort of national strategies. So what can we do across Wales, what we work with the sim societies, because there's a sim society in the UK called ASPI, and it's really good, again, to have that collaborative vision about where we can take simulation. We've worked with international programs, and with my work internationally, I'm very keen to do that. But we've done faculty development even as far as Zambia, which is just amazing because, again, it's all about expanding the capabilities to be able to run simulation so we can improve patient safety.
Is it sometimes hard to get people to focus on this when really the big stories about the NHS are often the fact that it either is or appears to be in crisis, and that I think there's, at time of recording, there was a dreadful story from it is the English NHS, but of the woman who's found underneath a coat in A&E after 7 hours and died afterwards and all this sort of stuff. And that's what people are really concerned about, is the fact that A&E doesn't seem to be working in lots of scenarios. And so is that responsible sometimes for detracting from you talking about the importance of training at the more grassroots level?
I can understand the concerns, but I actually think it's more reason to do this, because we really need to find sustainable ways of increasing the numbers of students training to be future healthcare professionals and retaining the healthcare professionals we have, and also to maybe adapt the training to a more realistic environment. So instead of doing scenarios where A&E is quite civilised, we can actually create highly immersive environments where
lots of drunk people. Yep.
And the cases, I often think people think of simulation as it's all about the cardiac arrest, it's all about the big disaster. But actually, the true value we're finding in the training we're doing is saying, what are our normal systems and processes, and are we doing that well?
Yeah.
And I think there's ways that we can look at not only increasing team performance, but also thinking, can we use this type of education and these immersive experiences to actually look at our systems and make systematic improvements?
And I assume, I've always thought that medicine seems to be fundamentally a very human thing, ultimately, and what you're doing there, or what you're describing there, is actually simulating the far more ordinary human behavioural experiences.
Absolutely. Because as we said, the actual causes of issues and patient harm, preventable patient harm, is very rarely skill-based.
Yeah. What does the future hold for all of this then? Obviously, the technology is just going to get better exponentially, I assume.
Absolutely. I think we can almost not keep up with the technology, and I think one of the things that we're keen to do is future-proof as much as possible. So even using the things like the immersive wall technology, it's highly flexible. It's not something we would have to change tomorrow if something bigger and brighter comes up. Same with VR, really. We've still got a long way to go with VR, because VR currently can only replace certain things in a curriculum, because you haven't really got the haptic yet, the touch sensation of certain procedures. So we're still growing and learning together. I think what's key, regardless of the technology, is that we continue training faculty and clinicians how to run simulation. But more importantly, we're sort of flipping it a little bit, especially as you mentioned before, AI changing perhaps the way we assess students. We are now looking at projects where students come in and research and create their own scenarios, run them for each other. And that means we're sort of building capacity for the future, where they will know simulation well, and they'll help to embed it not only into future education, but for systems analysis in situ in the actual hospital and community environments.
You have answered what I was going to ask next, which is that the way you've described the technology, it makes it sound brilliant. But obviously you must sit there sometimes and think, oh, if only we could also do X, Y, Z. Where would you love this to go, if there was lots of resources and money?
I think the next phase is trying to get more of the communication element into more of the virtual or holographic patients. We do a lot around things like OSCE examinations, so our assessments, where you can have 160 learners running through their assessments in a day, and you have to get patients and actors and train them. And although it's wonderful to do and highly immersive, it's also extremely time and intensive. So I think we have to look at where technology can really aid us to improve efficiency and effectiveness. And some of that will come with how we can interact in these virtual worlds, how much more we can communicate or have, like we say, haptic feedback. There's already gloves that you can wear, so you can feel the touch and sensation. All of that, I think, is the next phase.
And if the Jo of 30 years ago doing her training
with a book,
her midwifery training, could see what's happening now, what would you be most surprised about?
Well, it's just incredible. I think just the fact that you can train in these environments that are so realistic that it really does prepare you for practice. I mean, I trained with the famous Miles midwifery textbook, and I remember being sort of an 18-year-old looking at a pelvis and trying to figure out which way round, which way up. And I think now you can just tangibly feel and touch and communicate and just strengthen your ability to give good care, because that's what it's all about at the end of the day.
Were there particular practices back in the day that just now seem so archaic?
I don't. In some ways, you probably would say yes, but in many ways, we had excellent healthcare clinicians, and
it's not that long ago.
Yeah,
obviously,
you get
That's terrible. That's
when I was a lass, but I think you relied a lot on the expertise around you, and you grew and developed over time. I think this is the thing. It does take many years to feel really confident and competent and probably be so. But I think now we're trying to equip. The biggest difference I feel is your ability to be able to speak up and be heard and be appreciated for that. And we have slightly less hierarchy in our healthcare systems. And I think we should maintain that and use that safe practice to grow.
you've made me really want to come in and have a look at the interactive
more than
walls and everything. It's
welcome.
been,
Yes.
well, hopefully I can. Thank you, Jo. Really interesting conversation. If you want to find out more about Jo's research, you can visit her staff profile page on Swansea University's website. To find out more about this podcast and Swansea University's research, visit swansea.ac.uk/research. That's all from us today. Thanks for listening, and thank you again to my guest, Jo Davies. If you've enjoyed this episode, please follow us. I'm Sam Blaxland, and that was Exploring Global Problems from Swansea University.